Today we'll go through a practical bedside approach to cranial nerve examination. The aim is not just to memorize 12 nerves, but to follow a simple sequence that you can use in clinic, ward rounds, or exams. Start with the core rule. Examine cranial nerves in numerical order, except cranial nerves 3, 4, and 6, which are grouped together because they all assess eye movements. And if you are doing only a quick screen, never miss the essentials. Fundi, visual fields, pupil size and reactivity, extraocular movements, and facial movements. Cranial nerve 1 is the olfactory nerve. It is often omitted in routine screening, unless the history suggests a problem or there is suspicion of inferior frontal lobe disease, such as a meningioma. Ask the patient to close the eyes and identify a mild, familiar smell such as coffee or toothpaste. For cranial nerve 2, start with visual acuity. Use the patient's usual correction, so glasses or contact lenses should be worn if needed. Check acuity using a Snellen chart or a similar tool. Then move to visual fields by confrontation. The patient faces you at about 0.6 to 1 meter or 2 to 3 feet and looks at the center of your face. Place your hands in the periphery, midway between you and the patient, and ask them to say when and where a finger moves. Start with the inferior quadrants, then the superior quadrants. You can move the right finger, the left finger, or both together. Still in cranial nerve 2, examine the optic fundi. Think systematically. Optic disc, retina, and vessels. Look at disc color, size, swelling, or elevation. Then assess retinal color and texture, vessel size and regularity, arteriovenous nicking, hemorrhages, and exudates. For cranial nerves 3, 4, and 6, begin with the pupils. Describe the size and shape, then test reaction to light and accommodation. Check convergence by asking the patient to follow your finger toward the bridge of the nose. Then assess extraocular movements by asking the patient to keep the head still while following your finger in horizontal and vertical planes. While testing eye movements, actively look for paresis, nystagmus, abnormal smooth pursuit, saccades, or oculomotor ataxia. If needed, check eye alignment using the corneal light reflex. Ask about diplopia in different directions of gaze. True binocular diplopia should usually disappear when one eye is closed. Horizontal nystagmus is best assessed around 45 degrees of gaze, not at extreme lateral gaze, and the target should be held there for a few seconds. Cranial nerve 5 is trigeminal. Test facial sensation in the ophthalmic, maxillary, and mandibular territories on both sides. For screening, use 2 modalities from different pathways, such as light touch and temperature. If suggested by the history, test the corneal reflex. For motor function, ask the patient to clench the teeth and assess the masseter muscles. Cranial nerve 7 is facial. Look for facial asymmetry at rest and during movement. Ask the patient to raise the eyebrows, wrinkle the forehead, close the eyes tightly, smile, and puff out the cheeks. Forehead sparing suggests an upper motor neuron lesion, while weakness of the entire side of the face suggests a lower motor neuron lesion. For cranial nerve 8, screen hearing with finger rub or whispered voice in each ear. If abnormal, proceed to Rena and Weber tests. Rena compares air conduction with mastoid bone conduction, and Weber checks lateralization using a 512 Hz tuning fork at the center of the forehead. Any suspected hearing problem should be followed by formal audiometry. For cranial nerves 9 and 10, observe the palate and uvula at rest and during phonation by asking the patient to say, "ah." The gag reflex can be tested by stimulating the posterior pharyngeal wall with a sterile blunt object, but remember, it may be absent in normal individuals. For cranial nerve 11, test shoulder shrug against resistance for trapezius and head rotation against resistance for sternocleidomastoid. Finally, cranial nerve 12 is hypoglossal. Inspect the tongue for atrophy or fasciculations, assess its position on protrusion, and test strength by asking the patient to press the tongue against the inner surface of each cheek. The key is to be systematic, compare both sides, and use the pattern to localize the lesion.